Thank you so much for the invitation to come. I'm very thankful to be here with you all. My name is Kevin Bielamowicz. I get a lot of interpretations of my name, so it's totally fine. My favorite one a couple of months ago is I had a patient call me Bielamowicz, which I thought, I looked at him and I was like, oh, okay, that works. But people call me Dr. Kevin or Dr. B, but I'm a pediatric oncologist at Arkansas Children's Hospital in Little Rock, Arkansas. I kind of have a few different areas of interest that really converge on NF, and that includes early phase clinical trials, pediatric neuro-oncology, or brain tumors, and cancer predisposition. And so that's where my involvement in NF really blossomed from all of those interests coming together. So my hope, I do have a couple of disclosures for this talk. I will be talking about patients enrolled on clinical trials and also off-label use of treatment medications, which I'll also talk a little bit about what that means. Any photos of particular patients' faces, they did give consent for me to use. And then I have served on a couple of advisory boards for pharmaceutical companies. So I will give a very brief oncologist introduction to NF1. And so after that, I'm going to go over a little bit, I'm going to go over how to manage pediatric neurofibromatosis type 1 associated tumors. But my goal of that is not necessarily that you come away from that with names of drugs and exactly how to manage each of these particular situations, but more kind of the terminology involved in it, so that if you see a press release or you look at an article, you can kind of get a feel for exactly where that is in the pipeline of development, or how it may impact you or your child, or how far away it may be, if ever, from actually being able to impact patients. Great. And so when I think of neurofibromatosis type 1, once again, in my simplistic view, there's a change in a gene that leads to a change in a protein. And that protein has a lot of vital functions. And the protein that's made by the NF1 gene, neurofibromin, it affects a lot of different things, like in growth and development, how different cells migrate to different places. It regulates levels of different chemicals like neurotransmitters. In my world, it is a tumor suppressor gene or a tumor suppressor protein. So it kind of puts the brakes on cells growing out of control. And when that protein is altered, all of these different processes can be affected and leads to the different manifestations that we see of the condition. NF1 is a very common condition, relatively speaking, compared to some other things that we see in pediatrics. We have about 15 to 20 new kids with NF1 born each year in Arkansas. Kansas would probably be pretty similar. Missouri, maybe twice as many. And that translates to, a couple of thousands of kids in the United States each year. And so relatively speaking, our clinic in Arkansas follows about 200 kids, 300 total kids, and we see about 200 kids with neurofibromatosis type 1 annually. In about half the new kids we see will not have a family history of it. It'll be a new mutation to that child, which is not super common in the world of genetic conditions, but and so there are a set of diagnostic criteria. There are these major criteria that if you have two of these clinical manifestations, we give you a clinical diagnosis of neurofibromatosis type 1. And I think many of us are very familiar with this, but it's some skin manifestations, these dark patches called cafe au lait macules or freckles under the armpit or in the groin region. Certain types of tumors like neurofibromas or these brain tumors called optic pathway gliomas can be some of these major criteria. There can be changes in the skeleton or the bones in certain areas that can be one of these major criteria if you have a parent with NF1. And then also if we actually find a change in the NF1 gene that we know can be associated with neurofibromatosis type 1. And so I have a slide with a few of these in picture form. And so, these top three here in this top corner is, these dark patches called cafe au lait macules. Here is some axillary freckling. These are some growths in the eye that are called Lisch nodules that are not tumors. They're just some abnormal growths. All of these manifestations usually don't require any treatment. I think it's key with these dark patches. We love seeing kids in our NF1 clinic that just have a couple of these patches, but really don't have diagnosis of NF1. Not everybody who has those cafe au lait macules or dark patches will have NF1. And so we love seeing kids and kind of letting the family know that we do not think that the patient has that diagnosis. But there are other manifestations of the condition that are major criteria, such as this very large neurofibroma in a patient of mine, or this growth right here on the optic nerve, which is one of these optic gliomas that can impact the vision. And so just a few pictures of some of these manifestations. But, as I've kind of been seeing kids with NF more and more, my mind shifted from this, these criteria that somebody has to fit to meet that diagnosis to really thinking a little bit more holistically about patients and really what all do they need in order to address all the aspects of their care. As you will hear from our panel of speakers today, with just a lot of different facets of life really that can be impacted by neurofibromatosis. And so this is Zayden, one of my patients. And here's our team at Arkansas Children's. I don't really like to, sometimes I do rank in my mind who are the people in our clinic, the providers who are most impactful with our families. And where I often arrive on is that Dr. Scott, our neuropsychologist, just does such an amazing job talking through families what the needs of individual children are from a developmental standpoint. Leslie Oslisa is our kind of patient family advocate who meets with all of our families to really kind of help them get connected, as this amazing group is doing as well. We also have our core members, including neurology, genetics, Dr. Sellers, myself. We have a nurse coordinator that kind of runs the show in our clinic. And then we kind of have that core group of folks who are in clinic all the time. And on the same day, we kind of have what we call satellite appointments with the eye doctors, with one of our surgeons that specializes in neurofibromas, with our orthopedic doctors that deal with some of the bony concerns that we can see, with our endocrinology team who can address issues like bone density and other hormone irregularities. So we kind of have this core group, and then all of these, we call them kind of satellite appointments that patients can go to if needed. And that's really how I think more holistically about a child with NF, what are the needs and what are the concerns that could come up throughout their journey. I will transition to talking a little bit more about tumors associated with neurofibromatosis type 1. And if I kind of think of all the different ways that we can treat tumors, you can take out a tumor, surgical resection. In a lot of cases, if you can do that adequately and almost completely, that's all that you need. We can do traditional treatments like radiation and chemotherapy. And those do typically have some particular side effects. And so we definitely don't enter into the decisions to use those treatments very lightly. Immunotherapy, I think, has a lot of buzz, but basically it's somehow harnessing the immune system to really fight tumors and cancers. And what has really blown up in really all of the neurofibromatosis spectrum conditions in the last decade or so has been the use of targeted agents. And when I say targeted agents, it's really more, you can think of them as chemo pills as you want, but they're really more medicines that kind of stop the pathways that are kind of overactivated with the NF1 gene change. And so MEK inhibitors is the class of targeted agents that are most commonly associated with NF type 1. The two main types of tumors in pediatric NF1 in kids with NF1 that we have, that we encounter the most are plexiform neurofibromas, which are benign tumors that are extensive. They're sometimes deep down underneath the skin, wrapping around things, causing symptoms. And then low-grade gliomas in the brain. The most common type is the optic gliomas, which we'll have a couple of talks about a little later today. But there are these low-grade brain tumors, low-grade gliomas that can happen anywhere in the brain, really. And I think the key thing about these plexiform neurofibromas are considered benign tumors if you look at them under the microscope. Low-grade gliomas are kind of more of a gray area, and it's always, I think what families want to know about tumors is it benign or is it cancer? And a low-grade glioma is kind of in this middle ground in that it's not malignant or aggressive. It doesn't tend to spread. It doesn't tend to be life-threatening, but it's also not benign, and so it's kind of in this middle ground. But these low-grade gliomas of the brain and these plexiform neurofibromas or deep extensive neurofibromas are the two types of tumors that we encounter most commonly in children with there's been a lot of press recently about selumetinib, which is a MEK inhibitor. It's a targeted agent that's kind of a chemo pill that's more specifically targeted to the pathways associated with NF1. This is the original New England Journal paper that showed some responses of these neurofibromas to just the single by-mouth chemotherapy medicine. And this was published, gosh, already 7 years ago. So the research with it started probably even more like 10 or 12 years prior, but really revolutionized the field. So these tumors that really didn't respond to many of the treatments that we have, they weren't amenable to surgical resection, now had a pill where you could kind of shrink them up and really manage them over time. But what I noticed is as selumetinib started to become more in the mainstream, is that I really had to take the time with families to make sure that what its role was clear. And I try to meet with all of our families, regardless of whether their child has tumors or will ever develop tumors, just to kind of make sure they don't have any questions, make sure they understand what may develop, what we're looking out for, and then really see if they have any questions about things that I've read. Because like we just mentioned, having the world at your fingertips with information is fantastic, but it also can be extremely overwhelming. And I think, I definitely have families that talked about the utility of selumetinib for their child. And in reality, it wasn't something that they really had a need for that. And so really being able to explain that, this is not a pill that kind of fixes all of the complications of NF, and that it has a very defined role. And so with that, I kind of started, I don't by any means go into a patient's room and go through all of these different concepts in clinical trial progression with families, but it did kind of make me take a step back and think, families started coming with a lot of different questions. For instance, I had a family come to me and ask if this study was relevant to their child. And first of all, I had to go read it because I had not seen it. And really, the idea of gene therapy in NF1 is not something that I'm an expert in. And I really had to educate myself. But then was able to go circle back with that family with the idea that this is a preclinical study, meaning that it was just in the lab. It wasn't something that was really, that had made it to people yet. And so the idea of, that's the kind of the concept up here of this first slide is that this is a preclinical study. And so I welcome my families to bring that information to me because they see these things that sound really promising. This gene therapy to really fix the production of that abnormal protein in NF1, but in reality is not quite at a place where it's ready to help their child at this point in time. And so that terminology that you may see is something called a preclinical study or a study in the lab. This second line right here has a couple of different terms: orphan drug status, fast track, rare disease designations, breakthrough designations. If you read about a medicine that has one of those, it sounds really exciting, and it really is. And what it means in my mind is that the government is kind of saying that this is promising, and they want to help pharmaceutical companies and researchers design studies in a way that if this ultimately ends up helping patients, it kind of helps it get to the end goal of FDA approval and really impacting patients' lives quicker. But in reality, anything that has these status are in development still. They're not quite, because the goal of these designations is to help something in development kind of reach that end goal better or more quickly or more efficiently. So if you see any of those terms, breakthrough status, rare disease designation, those are great things that help develop treatments. But in reality, those things probably, once again, are not, they may be in clinical trials, but are not something that I can just prescribe to you or your child. This is a patient, I showed this picture earlier, but a child of mine who's, gosh, she's now 14, but she has just, a very large head and neck plexiform neurofibroma, a deep tumor. It's benign. We aren't really able to have a meaningful surgical resection of it. We did attempt that once. But at the time, back in 2016, when this child was really, when the family was really looking for treatment options, we did have a clinical trial at our institution open with a medicine called cobimetinib. Now, you may see that sounds a lot like selumetinib, and we did look into our patient going to other places to take part in a clinical trial at the time with that medicine as well. but ultimately the family decided to stay close to home and do the clinical trial with the medicine that we had. Now, this study with cobimetinib at the time is what we call a phase 1 clinical trial. And what that means is it's kind of the first clinical trial for that medicine in people. And the goal of that study is more to look at the side effect profile. This was a clinical trial that didn't just have kids with NF1 and tumors in that study, had other types of tumors as well, but it did allow kids who had tumors associated with NF1 because it's a medicine that made sense for those kids. And so, but this was a study that was run through a consortium that we have. The goals of the study were to find safe and effective doses and to establish the side effect profile. Ultimately, this did not move forward to development like selumetinib ended up doing, but it's a good example to me of just a case where a child participated in a phase 1 study, which was kind of an earlier study in the development of this medicine. This is another patient of mine that has a really large neurofibroma in the neck that was causing things like swallowing dysfunction and problems with breathing. And so once again, talked about a lot of different options on how to treat this, meaning that, and we could just keep watching this. We could try to debulk surgically the tumor, but it's just in a very sensitive area. We talked about off-label use of certain medications of a different MEK inhibitor called trametinib. And what off-label use means is that a medicine has FDA approval for something, and you're going to use it for something else. So really, you probably have a good feel for what the side effect profile is. You have a good idea of what you need to monitor for, how it works. But in reality, you don't have that approval for the reason that you want to use it. And so that was an option in this situation. We had a clinical trial open at our institution of a different MEK inhibitor called mirdametinib. That study is still open, and it allows pediatric and adult patients to enroll to treat neurofibromas. One challenge for this 5-year-old was that they couldn't swallow pills. And so this is something we encounter often, is that a certain medication, you may be limited in the ability of a child to receive a certain medication or be a part of a clinical trial because they can't swallow tablets whole. And so in this situation, these options of the off-label medicine and the clinical trial medicine were liquid formulations that the patient should not have trouble physically taking by mouth. And so they ended up taking part in this a clinical trial that we had with this medicine called mirdametinib. This was a phase 2 study, meaning it had already kind of gone through that phase 1 study. So we had the dosing that we thought was the right dosing. We had the side effect profile to some degree. And then this phase 2 study, the goal of this study was to see if it worked, to see if it actually in a certain percentage or a significant percentage of kids actually shrunk up their neurofibromas or improved their symptoms in a way that we thought was promising or met certain endpoints. And so this is an example of a child who enrolled in a phase 2 study. So not just, we're still looking at side effects, we're still looking at how safe is the medication, but the primary goal of a phase 2 study is more looking at how well it works. Now, during this patient's journey on this medication, selumetinib became FDA approved, and so definitely circled back with the family about that information, and ultimately the child was tolerating this medicine well, and so we kind of decided that that would be a nice resource potentially in the future. But this is an example of a phase 2 study. This is a patient who has NF1 and had a very large brain tumor. Our neurosurgeons were able to take out a good bit of it, but not maybe we'll say maybe 50% of it. And at this point, after that surgery, at some point this had grown, and it might be reasonable just to continue to watch it. We can treat these brain tumors, these low-grade gliomas associated with NF1 with traditional chemotherapy, which is usually medicine given through an IV. It kind of has some of the side effects you think of that can be associated with chemotherapy if you ever had anybody in the family who've had cancer or been on chemotherapy medicines. But then we also had clinical trials of some of these same targeted agents through a group called the Children's Oncology Group that this child could be eligible for. We have some nice evidence. Selumetinib is currently FDA approved. I'll talk about this in just a second for the deep or plexiform neurofibromas that are not amenable to surgical resection and are causing side effects. But this is an initial study that was done. This was the phase 2 study with selumetinib. in kids with NF1 who had brain tumors. And this is kind of the percent change in each individual child. Each bar indicates a child who is on this medicine. And you can see that really all the patients, none of the patients had growth of their tumors, which would be reflected in a percentage change upward, but all to some degree had shrinkage, and many of them met the endpoint of having 50% shrinkage in their tumor. So selumetinib, very helpful for many kids with the neurofibromas, but then had a very clear signal in this phase 2 study looking at how well this medicine worked in kids who had brain tumors with NF1. And so with that, we are now part of what's called a phase 3 study with selumetinib in brain tumors. And what that means is that you are comparing it to what you consider is the standard of care currently. So the phase 1 study, I like to think of it as kind of man versus drug. What are the side effects? What's the right dose? Phase 2 study is kind of drug versus the disease. You're looking at how well does the drug work against a particular condition. And then a phase 3 study is drug versus drug. You know, you're comparing 2 treatment regimens to see if one is better than the other. And in this particular situation, child with NF1, they could enroll on a clinical trial where they would be randomized. Hard concept when you're thinking about your child, that you don't have that control of what path they will go for treatment of their tumor. But in this particular situation, they could be enroll in this clinical trial and either get traditional chemotherapy in the beginning or the targeted medicine selumetinib for their brain tumor. And conceptually, this is hard in kids, you know, that we're going to randomize them, but in reality, it's the best way to answer the question as to which one of these is better. And so we don't know if selumetinib for brain tumors will be better than traditional chemotherapy. We think that it has a role for sure. But this is an example of a phase 3 randomized study where we're comparing standard treatment to newer treatment. And so there's kind of the phase 1, 2, 3 that we've kind of talked about a little bit. This is, I really like this patient's story. He's a 12-year-old male who clearly had a clinical diagnosis of neurofibromatosis type 1, but just, you know, for whatever reason, he was doing well and just it really hadn't been picked up by providers that he has seen, not an uncommon story. But he presented to our emergency room with blood in the urine. And we did some imaging, and this is the patient's bladder, and there's a large tumor in it that was likely causing bleeding. And so we talked to our urologist, the appropriate surgical specialist that could potentially remove this, and they thought that it was just such a sensitive area that should really be considered a, you know, kind of a last-ditch effort. And we did a biopsy of it. We were, you know, based on the imaging, we were actually expecting it to maybe be something more aggressive the way it looked. And so thankfully, this was a benign neurofibroma. These can happen anywhere in the body. And so, and this was not maybe the most common location that we see them, but the patient had a benign neurofibroma associated with NF1. We talked to the appropriate surgical services who really thought that this was not the right thing to try to remove this. And so we started the patient on selumetinib. It was causing symptoms with the blood in the urine, not resectable. And in my mind, a very clear situation where this is where selumetinib, you know, very clearly meets the FDA-approved indication. And the patient started on the medication. About a week or two later, their hematuria or their blood in the urine had completely resolved. And we saw that shrinkage on the imaging too after several months. Patient continues on the medicine today, about 3 years out from starting it. But just in my mind, a great example of a patient that very clearly met, in my eyes, the FDA-approved indication for the medication and benefited from it. This is, I showed this patient earlier, but this patient, the short of it is that he had a brain tumor in this back part of the brain called the cerebellum. It's one of these low-grade gliomas that was associated with neurofibromatosis type 1. He had what we thought was complete surgical resection of it several years back. And then we kind of watched him with scans after that surgery without any other treatment. And then unfortunately it came back. And so at that point, you know, talked about a lot of different options with the patient who is now an adult. And so had, not that our pediatric patients don't have a huge role in what their treatment plan will be, but in a 20-year-old now, he had, you know, very clearly had to make that decision. This patient was very clear he didn't want any more surgery. He didn't want to do radiation. And so we decided to pursue a MEK inhibitor. Didn't really have any clinical trials out there that that were available for adults with brain tumors and NF1 with a MEK inhibitor. And so we decided to use selumetinib off-label, once again, using it for a different indication than what the FDA has approved it for, and just had a very nice response with, there's probably still some tumor there, but just a very nice response. And similarly, has been on the medication for a while, tolerating it well, with a really nice response in the tumor, so achieved that tumor control. But a nice use of off-label use of medication when you think it's in the patient's best interest. There's a lot of other terminology, FDA approval. Sometimes it can actually be conditional in COVID. In the COVID area, we've all kind of heard emergency FDA approval, with the FDA kind of both with conditional and emergency approval. Those are kind of given with conditions on it that things will be reevaluated over time, as opposed to more full approval. If I won't talk about, I know we have other optic pathway glioma studies, but we have a clinical trial at our institution, like a lot of other institutions that treat kids with neurofibromatosis, with what we call a natural history study with optic pathway gliomas. And what that means is that kids who on imaging have an optic pathway glioma, we enroll them on this study, and basically we just follow them. We kind of send their scans to a central location. We send very limited clinical evaluations, their eye exams. And the goal is really just over time to try to answer questions clinically about that. But it's not a situation where on this clinical trial, patients are receiving any different intervention. The intervention that they receive for their tumor is based solely on the provider at their institution. But we just want to collect a lot of information so that we can then try to look at things and say, hey, do these kids, are there any particular signs on the MRIs or in blood work that might point us down different directions of kids who ultimately need treatment? And so this is what I would call a non-interventional study. It's something where, in reality, there might be an additional blood draw that we wouldn't have done before, but the child is not receiving a treatment, or any treatment decisions are being made based on the clinical trial itself. It's really more to help collect information and answer questions in a non-interventional way. So thank you very much once again for the invitation to speak. Happy to answer any questions about kind of how I think about clinical trials and tumors associated with NF.
We'll start by taking any questions live, and then we'll see if there are any in the chat room. Not in the chat room yet. Any questions? Oh, we have a few here.
Yeah. Can you speak to any of the potential side effects with selumetinib or any, mechanisms?
Yeah, and it's interesting. I think selumetinib and other MEK inhibitors have really revolutionized the field, right? It's so great to have a medical option when none really existed before. The way I think about it is that there's kind of some short-term side effects that you can even kind of become accustomed to or grow out of, for lack of a better way of saying it. And then there's kind of some rare but serious side effects that we need to monitor for. The rare but serious side effects, we get heart ultrasounds to look for evidence that the drug is preventing the heart from squeezing appropriately. And we get eye exams to look for several rare complications of the vision that can happen with really any MEK inhibitor, like selumetinib. In reality, those are usually short. If you hold the medicine, those side effects usually get back to normal, so they're not usually permanent. And then often you can even restart the medication at a lower dose, and those side effects don't happen again. So the eyes and the heart are the things I think of, the things we need to watch closely for, but usually if those side effects happen, they're not permanent. And then there's a lot of short-term side effects that can happen: upset stomach, loose stool, problems with the toenails, rashes, a lot of things that usually don't limit your ability to give the medicine. But as we've given them more over time, I've really talked to families about tell us right when they happen so that we can really try to intervene for them. The first day that you have that rash, I try to counsel families in the beginning, because a teenager that's starting it, it might not sound like getting an acne on the face is a big deal, but have definitely had a patient stop the medicine because they didn't like that side effect, which totally reasonable, but try to kind of counsel regarding those side effects. But I kind of think of those those not as serious side effects, but that we may have to support the patient for. Sometimes those can get better over time, and then kind of the rare but more serious ones that we have to monitor for more closely. One of the other limitations of MEK inhibitors in treatment of these tumors that I really try to counsel families on is that sometimes if you stop the treatment after a certain time point, the tumor will grow back. If you had shrinkage of a plexiform neurofibroma or a shrinkage of a brain tumor with the patient we saw, if you stop the medication, they can kind of regrow after. So how long you're going to treat is still, I think, an open-ended question. We kind of do it for 2 years because we know we can see ongoing responses and tumor shrinkage even 2 years out. So if a patient is responding appropriately and tolerating it well, we usually at least give it a minimum of 2 years, or at least try to get to the point where we think the tumor shrinkage has stopped. And then kind of have a conversation with each family and each patient about whether continuing or moving forward. So yeah, definitely a lot of nuances to the side effects and kind of preempting families before we make the decision to enter in with that treatment. And then also a lot of questions about duration of treatment and afterward.
My question is there like a, I'm sorry. My question is there like a blood test that they need to do when they have all those spots? Or because my daughter, we didn't know she had this until she was 19 and she developed a primal tumor. So should we have requested a test when we saw the spots or?
Yeah, it's a good question. You know, and I'm getting out of my lane a little bit, so I apologize if I dance around your question a little bit, but in our clinic, we do offer any child that sees us in our neurofibromatosis clinic, if they have a questionable or a clear clinical diagnosis of neurofibromatosis, genetic testing for the particular gene of interest and maybe some other associated genes. But as far as whether, I think the route that happens more commonly at our institution is that children are referred to our clinic for a clinical evaluation and then have a conversation about whether the genetic testing is appropriate for any individual family. I hope that answers your question. I didn't dance around it too much.
Is it possible for internal,
So folks can hear online a little bit easier.
is it possible for internal neurofibroma to ever shrink on or without treatment?
It is, I think what we see more commonly, and I think it should be a part of the conversation about whether to move forward with treatment, is that sometimes a tumor that grew when a child is 7, 8, 9, 10, 12 years old may not grow when they're 18, 20, 22 years old. And so to enter down a road of a surgery that can have side effects or a medicine that you really don't know what your endpoint is with it. I think part of the conversation should be is, what has been the rate of growth and do we anticipate that, is this kind of slowing down? Could it kind of stay where it is? And in reality, the treatment might pose more problems than the tumor itself. As far as regression, absolutely can see that. It's not something that I expect, and it's not something that I usually make decisions based upon, but absolutely have seen that in some situations. But I think even more so, it's that the rate of growth can definitely slow down and they can become very stable and kind of enter into that phase for decades.
Thank you very much. You had mentioned the young boy that had the neurofibroma in his bladder and that he was on selumetinib for 3 years. Do you anticipate a certain time where he'll be coming off drug, or how does that, is there a finish line, I guess is what my question is?
Yeah, that's a great question. I think it's probably one of the big, I think it's more of an individual conversation with each family. I think we often expect that if you take a child off of the medication, that either their brain tumor or their neurofibroma will start to grow again. We have definitely seen that in several situations, but also think that, like I mentioned a second ago, that if a child gets older, it may not grow like it did before. Kind of another condition called tuberous sclerosis, where we have targeted medicines that have been around for a lot longer. I've had patients who've been on those targeted medicines for 10 or 12 years, And now I'm starting to wean patients off of them as they become adults and they kind of make that decision. And most of their brain tumors, once again, different condition, but they really haven't accelerated in growth again. And I think it kind of fits the time frame and the natural history of what we expect with those particular patients. And so I think there will probably be a similar dynamic in neurofibromatosis type 1. But in reality, it's more of the age of the child. You know, the younger you might expect more growth if you come off of the medication. How well are they tolerating the medication? And really every family is kind of, I feel like, come to a different conclusion about whether they want to keep going or whether they want to try off of it and kind of see how the scans look. So once again, no great answer for you, but I think it's a huge unmet need as far as exactly knowing in what situations might be best to stop the medicine after a couple of years versus continuing on. But and I don't know that I have a great trend on what I think every family is a little bit different in how they think about it.
Actually, I don't know, Sharon, if there's more time, but we did get a couple of questions. Thank you.
Yeah.
We did a couple more questions online. The first one is, do certain NF tumor types tend to proliferate during puberty more than others?
Yeah, you know, not necessarily. I mean, I think sometimes we, I don't know, I will mention that to families as something, but I don't think that's really borne out in clinical practice in my experience. And I welcome anybody else's thoughts if they see that more often or not.
You know, I would say it's an overwrought, over concern from families and patients. It's not like the moment you start going through puberty, neurofibromas grow all over the place. My experience, it's more likely to happen in women who are pregnant, who have gotten in one area, neurofibromas growing, but it's not like the moment you start developing breasts or hair that they're going to pop up. And that's one of the big misconceptions in my mind.
Absolutely. So I usually mention it because they might read that, but at the end also kind of temper their concerns because it's not something that usually bores out clinically. It makes sense that it might happen based on the hormones, but in reality, yeah, it's not something that we typically see as much.
I'm going to go ahead, Sharon, until you tell me I have to stop with the questions. Okay.
Until our timekeeper raises her. Once the timekeeper here who is going to pull you off if you run over, but you're fine.
Right. This one is, can you speak to the balance between intervention early and waiting to see what happens? My son has a largest PN in the area that it could be surgically removed, but we were advised just to scan annually. Why wait, risking the chance that it could be too late for intervention successfully?
Yeah, man, I hate to comment on the particular situation. I think this is to some degree, the art of the management of these and kind of looking at the rate of growth. It just depends on, you know, personally, I think it's my responsibility to find the appropriate surgical specialist for whichever neurofibroma in whichever location that might be, and really have them talk to the family about what the potential side effects of the surgery might be. But in reality, sometimes it is the right decision to just watch. And but I really hate to comment too much about any individual situation. But I would say the overwhelming majority of times, the right answer, even with deep plexiform neurofibroma, sometimes even when they're causing symptoms, is just to watch. And I know that that's a really hard concept. I don't like doing it as a provider, and I'm sure as a family or as a patient, that's a really hard thing to come to grips with. Why wouldn't we just intervene sooner? And the answer is that you may not need to intervene, and sometimes the treatment can be more harmful than the tumor itself. And it's really just about weighing those risks and benefits in every particular situation. But I completely understand that it is a very, it's not a very comfortable position to just be watching something you know is there, especially if it's causing symptoms or if it's had growth.
Thank you. One more, right? I think though there's a typo on this one, but it says, is neurofibromatosis in any way linked with slow weight gain? It was the word neurofibroma, but I think is neurofibromatosis in any way linked with slow weight gain?
I don't know the answer. Anybody?
Absolutely not.
Yeah.
If there's somebody's not gaining weight, with rare exception, it's for another reason.
Okay, that's all the questions here. Let me just peek in the chat room.
Got the red card.
We got the red card. Okay. All right, well, thank you very much.